Hello and welcome to the weekly health webinar brought to you by JKYog and Radhakrishna Temple of Dallas. February is American Heart Health Month, a perfect time to learn about cardiovascular or heart disease, which is the leading cause of death in women and men. Cardiac disease is often thought of as a man's disease, but this is a common misconception, and many women do not know of their risk. Fortunately, research has shown that 80% of cardiac and stroke events may be prevented with education and action. To review heart disease in women and educate us on what women can do to improve their cardiovascular health, we have with us today cardiologist Dr. Deepika Gopal. Dr. Deepika Gopal is a clinical cardiologist and cardiac imaging specialist with Baylor Scott and White Cardiology, the Heart Group Plano, and is on the medical staff at the Heart Hospital at Baylor Plano and Baylor Regional Medical Center in Plano. Dr. Gopal completed her cardiology fellowship at the Barnes Hospital, Washington University, St. Louis, Missouri. Her special interests include valvular heart disease, coronary artery disease, preventive cardiology, heart disease in women, among others. She is medical director of cardiac MRI at the Heart Hospital Baylor Plano and is actively involved in research trials and clinical research. She is also the author of the book Every Woman's Guide to Her Heart. We will have a brief Q&A after the presentation, so if you have any questions, do go ahead and submit your questions in the chat window, and time permitting, we will get to it. With that, I am delighted to welcome Dr. Gopal. Dr. Gopal, thank you for joining us today. Over to you.
Oh, thank you so much, Ragini. It's my pleasure to join all of you this evening to be able to speak about heart disease and heart disease in women. Very relevant since this is the heart disease month in February, and would be very appropriate to talk about heart disease, as Ragini mentioned. And I will start with some statistics. I will focus on ethnicities specific to South Asian Indian women. So it's going to be a lot of data, but important data that I think people need to know. And so you could really improve your awareness about heart disease. It's the #1 killer of women in the United States, claiming more lives than all forms of cancer combined. And this map shows death rates from the heart disease, in women in the United States. Darker red areas certainly indicate higher incidence of heart disease, as you can say. This is for all comers, all women in the United States. So that's pretty impressive. As you can see, this is area of Texas and surrounding states. There appears to be a lot of heart disease. And so despite increase in awareness over the past decade, only about half, 56% of women actually recognize that heart disease is their #1 killer. So that's a very low percentage if you see that. It's the leading cause of death for women in the United States and about 1 in every 5 female deaths. Heart disease is the leading cause of death for Afro-American women as well as white women in the United States. Among American Indian and Alaskan Native women, heart disease and cancer roughly cause the same number of deaths each year. For Hispanic females and Asian or Pacific Islander women, heart disease is second only to cancer as a cause of death. South Asian heart disease, or Asian Indian heart disease, is how we like to call our race. As you can see, this was a study done in the United Kingdom, and look at the standard mortality ratios for coronary artery disease by country of birth in the United Kingdom in men and women aged 30, as early as 30 years, look at that age, to 69. And this is data back from 2003, but you'd be surprised that there isn't much that has changed on this data. If you look at people of Indian origin living in the United Kingdom, actually red are men and blue women. You can see more women than men die from heart disease. women from Pakistan, again, at a higher risk than their male counterparts. And in England, though, seems to be equal. Singapore, coronary artery disease mortality among Asian Indian women, 30 to 39 years of age, very young. I mean, you don't even think, you can have heart disease at that age, but certainly Asian Indian women are at great risk of early heart disease even in the premenopausal years, which is what makes Indian women stand out. Asian women, particularly Indian women, stand out amidst all other races. So between the age of 30 and 39, incidence of heart disease was 8-fold higher than Chinese women of the same age in Singapore. Asian Indian women in California had significantly higher proportional mortality rate for coronary artery disease. It was actually 144 Asian Indians versus 100 whites. So certainly we are at very high risk, regardless of where we live in this world. I think it's just the genetic makeup, and I will come to that during the talk. Angiography studies in Indians have shown high prevalence of severe and extensive disease, including all the 3 coronary arteries, up to 40% of the time, despite the fact that majority of these women, 56% were premenopausal women. You know how we talk about heart disease becoming equal, equal incidence as in men post-menopause in the Western society? Look in the Indian society, though, you can see premenopausal coronary artery disease, and some of them even have had bypass surgery by the time they've not even attained menopause. I think that's what people need to take away today from today's talk, the message that it is very, very high incidence in the Indian race, especially Indian women. In Canada, they did an angiographic study, and Asian Indian women were twice as likely to have left main or triple vessel coronary artery disease compared to white women. So certainly even in Canada, they found the same incidence. So the pattern, as you can see, regardless of which country the study was done, it's very similar. It says Asian Indian women are at the highest risk. Overall, heart disease rates among South Asian women are as high or higher than South Asian men, despite low rates of smoking. We don't find a lot of Indian women smoking, but they do have a higher incidence of heart disease. Atherogenic dyslipidemia, characterized by, high triglycerides, low HDL concentrations, and insulin resistance. The big 3, we see this combination very highly prevalent in Asian Indian women and appears to be the major contributor to heart disease. And the strongest contributor of all is high levels of lipoprotein a that is found in nearly 35 to 40% of Asian Indians worldwide. So really, these are the unique risk factors, unique to the Indian race that makes us very susceptible to coronary artery disease and heart disease. So here is from Inas et al.'s paper. I was able to download this from the internet. Look at this. This is a very large plaque. This is cholesterol plaque inside the right coronary artery that was removed during emergency quadruple coronary bypass from a vegetarian with high Lp(a) and no other traditional risk factors. So this certainly sends a very strong message. Just the picture itself is worth 1,000 words, that Lp(a), and even you could be vegetarian, but you're still at high risk. So that needs to be noted. Numerous case control and angiographic studies have shown Lp(a) to be a very powerful risk factor for premature coronary artery disease, as well as stroke amidst Asian Indians. Lipoprotein A is one of the few risk factors that's highly correlated with angiographic severity of coronary disease. There were more than 10 angiography and case control studies in India that showed elevated Lp(a) levels to be the most powerful risk factor for premature coronary artery disease, especially in those younger than 40 years of age. Blood levels of Lp(a), we can actually measure that when your doctor draws your labs for you. You can request an Lp(a) because it's an independent risk factor for heart disease, especially in diabetic patients too, in the Indian population. And they have isoforms of Lp(a). We can also measure those, and they're strongly correlated with coronary disease. And if you have low HDL or if you're diabetic, in addition to high Lp(a), I think that's sort of the perfect storm to set up coronary artery disease. Low HDL is also a genetic, it's sort of genetic. It is found in 92% of Indians. And the combination of high Lp(a) and low HDL is found in about 42% of the Indian population. And so, in summary, the combination of high levels of Lp(a) as well as homocysteine, which can also be measured when you get your annual labs done with your doctor, you need to request these, Lp(a), homocysteine, in addition to high prevalence of diabetes, metabolic syndrome, and Asian Indian dyslipidemia, and all together best explains the high prevalence of premature, severe, diffuse, multi-coronary vessel, malignant coronary artery disease among Indians globally. People from South Asia, not just India, so Pakistan, Bangladesh, Nepal, Bhutan, Maldives, and Sri Lanka, have a 4-time greater risk of heart disease than the general population, and they have a much greater chance of having a heart attack before the age of 50. Heart attacks strike South Asian men and women at much younger ages. As I said, they could even start at age 30, and these attacks are far more deadly compared to any other ethnic group. 1 in 3 individuals in this race die from heart disease before the age of 65. And in India, cardiovascular disease still remains the #1 cause of death. One study found that South Asians developed heart disease 10 years earlier than all the other groups. So there's incidence, this was looked at in Stanford, heart disease in young South Asians. 25% of heart attacks occur under the age of 40 for young South Asians, and 50% occur under the age of 50. So it's very young, right? 50 is young. South Asians develop coronary artery disease up to 10 years earlier than the general population on the average. And they have the highest hospitalization rates in the state of California for coronary artery disease, 4 times higher than any other ethnic population. People with diabetes are 2 to 4 times more likely to have heart disease and stroke than those without diabetes. So diabetes automatically puts you at the highest risk of heart disease as well as stroke, and we consider that to be a prior heart attack equivalent risk for the patient. So we treat all diabetics as high risk. In South Asians, diabetes and insulin resistance affects up to 20% of the population. So 40% higher chance of mortality in the South Asians than the average population. And according to a WHO report, by 2020, South Asians will comprise 25% of the world's population, but they will also suffer over 50% of the world's cardiovascular deaths. Again, heart disease is not just an issue for South Asian men. A woman's lifetime risk of dying from heart disease is 8 times greater than the risk from breast cancer. Heart disease in women has tragic consequences for family and society. So what is different about heart disease in women compared to men? Women are more likely to have an atypical presentation of heart attack, such as it could just be like indigestion or just a sensation of fatigue or tiredness, rather than classic chest pain or shortness of breath as described in textbooks for men. And women are also less likely than men to obtain preventative care for heart disease from their physicians. Women in general worry about their families. They're the center of the family. They're worrying about everybody else except themselves. And thereby, they're not taking good care of themselves. They don't go for their preventive care. When they have symptoms, they try to ignore it because something needs to get done in the house. So it's very important that women come forward with any vague symptoms and have that aggressively, diagnosed and treated. Women are also less likely to have aggressive management of their risk factors, such as high cholesterol with medications. They have higher mortality and morbidity rates from heart disease, and they're more likely to have a second heart attack rather than men. And they're less likely to receive timely intervention during a heart attack than men, simply because, they're presenting with atypical symptoms. It's going to, feel like it's bad indigestion or acid reflux or, almost like acid peptic disease. But in reality, it could be a heart attack. And that's why they may not get the timely treatment. These facts are startling and therefore should serve as a wake-up call to all South Asian women. But what are the symptoms of heart disease? Now I'm coming to a more generic kind of symptoms. In general, we say chest pain. It could be either a dull, a heavy, an achy sensation, a squeezing, a tightness, a vice-like sensation around the chest. Sometimes during the acute heart attack, they say it's like an elephant standing on my chest. So those are the classic symptoms, the classic ways that patients describe their symptoms. Pain in the neck, the jaw or throat, pain in the upper abdomen. So even the upper belly somewhat belongs to the heart, just because developmentally, pain from the heart can radiate, to the left shoulder, down the left arm, up the neck, to the lower jaw, and down as far as the upper belly or the epigastrium. So abdominal pain can sometimes be the only symptom of an inferior wall myocardial infarction involving the right coronary artery. Shortness of breath is an important symptom. Palpitations, when sometimes patients present with like malignant arrhythmias as the only presenting symptom. So they could have palpitations and sometimes frank syncopal episode. They can just pass out. And that should raise a very strong, immediately one should look for blocked coronary arteries as a possible cause. Now, other symptoms in women that makes the diagnosis especially difficult is they could have, indigestion. They also have nausea. They could have vomiting. They could just have fatigue or they just have dizziness. So if somebody has abdominal pain, nausea, and vomiting, you're going to, focus your attention on the gastrointestinal tract. And, sometimes they end up working the GI tract unless someone has gotten an EKG to check the heart at the same time, which could show you signs of an acute heart attack if it's done in a timely manner. Sometimes it is silent. Believe it or not, 50% of patients will not have any symptoms. And the first event is a heart attack. They present with a heart attack. If they're lucky, they make it to the hospital. They have their artery opened with angioplasty done acutely, and they make it through the hospitalization and discharged home safely. If not, sometimes they can have sudden cardiac arrest or sudden cardiac death without any warning signals. They may not have had any symptoms, and thereby, they've not gone to see the doctor, rightfully so, because they were feeling fine. And all of a sudden, the first event could be the heart attack that actually kills. So symptoms, again, chest pain, discomfort. They don't usually have pain. They say it's discomfort. It just feels different. Upper back, the upper back also belongs to the heart. There's radiating pain from the heart that goes to the upper back, to the neck area, and then to the abdominal, indigestion, heartburn symptoms like we talked about, extreme fatigue, upper body discomfort, and they could have dizziness and shortness of breath. They present with arrhythmia, like with palpitations, the fluttering feeling, like a bird fluttering in the chest, real rapid. And sometimes they present with heart failure, shortness of breath, swelling of the feet. You could have swelling of the legs, swelling of the abdomen, neck veins are all distended. So if you have any of these symptoms, the most American Heart Association and other websites say call 911 right away. So you could go to the emergency room right away. These are emergent symptoms. A stroke is also a medical emergency. You just get to the ER. So risk factors for heart disease. Who develops heart disease? So high blood pressure is one of the main risk factors. So is high LDL, the high levels of low density lipoprotein cholesterol, which is the blockage forming cholesterol. Smoking is one of the risk factors. About 47% of people in the United States have at least one of three risk factors. In women especially, it's important to focus on whether there is any history of pregnancy-induced hypertension or eclampsia. That could, lead to hypertension later on in life and increase their risk for heart disease. A few years ago, psoriasis, chronic inflammatory conditions such as psoriasis and rheumatoid arthritis were also included as risk factors for heart disease in women. So these are things that we certainly need to get, in the history of the patient coming to see us in the clinic. Several other medical conditions and lifestyle choices can put people at higher risk for heart disease. Of course, if somebody's overweight, obese. One thing is, although ideal body mass index, if you look at the American Heart Association website, says 24.5, in general for Asian Indians, upper limit is 22.5. We really cannot be at 24.5. We've got to be at 22.5 just because of the higher risk of the Asian Indian race. And other factors such as eating unhealthy all the time, physical inactivity. Most people have desk job, computer jobs, so we have to make time to exercise. Drinking too much alcohol is also bad. So, people may ask, how can I reduce my risk of heart disease? So things to do, first of all, know your blood pressure. Purchasing a home blood pressure monitor is a great idea because it's something you can take charge of your own health. You could monitor your own blood pressure at home, keep a nice log, just randomly check it once a week just to make sure that it's in the ideal range. If not, make sure you reach out to your primary care doctor and let them know. This is a self-monitoring task. And if you undertake that, I think a lot of people can avoid, further complications such as, going on to develop heart disease. Similarly, always make sure you get tested for diabetes because the incidence of diabetes in Asian Indians is very high. And smoking, has to go. I mean, if someone's smoking, they absolutely have to quit. There is no substitute for that. Regardless of, how many medicines the doctor can put you on, the smoking alone can single-handedly neutralize all the good effects of everything else that you're doing. So if someone's smoking, I think the best thing you could have done for yourself and your family is to quit smoking. And if you need, smoking cessation help, certainly your primary care doctors are available to help you with it. Check on your cholesterol, triglycerides, annual physicals with your doctor. Make sure you always keep your appointment. Always make healthy food choices as best as you can. 98% of the time, you must eat healthy. So what's considered healthy is mostly a Mediterranean kind of diet, like whole grains. If it's Indian diet, you want to go with whole grains, like your chapatis, your whole wheat. That's really good. Lots of vegetables. Olive oil is really, really very good. It's one of the better, healthier fats that we can use. Try to keep your body mass index below 22.5, and always manage your stress levels, either yoga, meditation. I mean, whatever is your channel, for stress release, certainly you should look into it because pent up stress causes, can do a number on the heart. So really, it's very important to de-stress and find ways to de-stress, and, get some time, quiet time to yourself and try to kind of relax. That's very important. So about cholesterol. Cholesterol is carried through the blood on lipoproteins, and there's two major types of lipoproteins. So when your doctor does your annual physical fasting blood work, you'll see a total cholesterol, you're going to see triglycerides, you're going to see HDL or high density lipoprotein cholesterol, which is the good cholesterol. I always remember it as H stands for happy, so HDL is the happy cholesterol. And it really serves like the liquid drainer. So it actually cleans out your pipes. So it's very important for us to strive to keep the HDL levels high, which we know is genetic, but healthy fats such as olive oil, healthy nuts are very healthy too. And exercise can actually raise the HDL. We do have some medications that can raise the HDL, but certainly it goes hand in hand with all the dietary and the lifestyle changes. LDL is the bad one. So L stands for lousy. So the lousy cholesterol or the LDL cholesterol is the bad cholesterol. That's the one that causes blockages. And really, we should strive to have the least amount of LDL possible. The goal in this day and age is we're recommending LDL levels below 100 for sure. And if somebody has coronary disease, we want it 70 or below. So that's the goal for LDL. We've gotten to a very aggressive, lowering numbers on that. And excessive LDL leads to everything, head to foot. It affects all the arteries. And thereby it causes anywhere from a mini stroke to a heart attack, angina, peripheral arterial disease. That's another big thing in people that are diabetic. Aortic aneurysms, everything happens because of atherosclerotic vascular disease, of which the main culprit is the LDL cholesterol. So here's a very nice picture of the cholesterol. I mean, look at this. This is a normal section of the artery. And look what happens. So cholesterol from blood seeps in through the inner wall of the artery and slowly starts building up the plaque. And this is the cholesterol plaque. You could see semi-solid fat. This is the lid of the cholesterol plaque. And look how it's encroaching on the lumen. Nature, being very kind, allows the artery to expand outward so that it doesn't compromise the lumen for a long time. But the more the cholesterol starts depositing, then it slowly starts impinging on the lumen. And when the lumen is greater than 70% blocked is when we end up putting a stent in patients. So I thought this would be an interesting picture for everybody. I just wanted to go over the anatomy of the heart so that people understand when you talk to your doctors or, you're talking to your friends or family. So here is the left main coronary artery. It's the biggest left artery, divides into two branches, the left anterior descending artery And then the left circumflex coronary artery, left anterior descending has branches here, the diagonal branches. Here is the other big artery, the right coronary artery that supplies the right side of the heart and the entire bottom of the heart in almost 90% of the population. In about 10-15%, the left circumflex supplies the left side and the bottom of the heart, and we term them as right or left dominant. And here is, of course, the aorta, here's the pulmonary artery. I just thought it's nice for people to kind of know, what these are, because I know a lot of you get your calcium scores done at the hospital, and, you get the score results back, and, then you want to know which artery, and this is available on the web. I mean, any website has it, So here are the varying grades of stenosis, okay? So this is somebody with, this artery actually looks pretty good, except for the fact that there is a little bit of cholesterol plaque that's built up in the wall. We call this mild stenosis. We call this severe stenosis, obviously, because, you can see this is the normal lumen. And if you have a lumen like this, obviously you're going to have exertional angina, and you're going to have a positive stress test. If you do a stress test with an artery that looks like this, it's going to show up as a positive stress test, requiring you to have an angiogram and a stent. Diffuse atherosclerosis is another specific condition that most commonly affects women. Women have this diffuse development of plaque everywhere, and not only in the major arteries, they have it in the microvasculature of the coronary tree. I have another picture. I'll show you what I'm talking about. This is the microscopic arterioles we see at the level of the heart muscle. And women seem to have, they don't need a stent. If you do an angiogram, this is not going to show. They're not going to need a stent. But they have classic chest pressure, shortness of breath, chest tightness with exertion, fatigue. And they have even a positive looking stress test. You do a cath, there's no need for a stent. But then that automatically, by default that this person has microvascular disease. And we can optimize this with medications as well as with enhanced external counterpulsation therapy. Here is a normal artery. Look how beautiful it looks. This is how we all look when we are in our younger years. And then as we get older, of course, for all of us, the cholesterol starts slowly getting into the wall of the artery, expands the wall of the artery, creates a plaque. And you can see this is a really tight blocked artery that needs a stent. Here are the different conditions we encounter as a cardiologist. This is where this person already has a plaque and the plaque has ruptured. Remember, when the atherosclerotic plaque ruptures, and I'm going to go to the previous slide, you see how there's an inner wall, like an inner lid? That lid is very hard, and it's supposed to be hard. Statin therapy, all the statins we prescribe, is able to make the lid very strong and prevents it from fracturing or rupturing. That can happen during periods of physical stress or emotional stress. And when it fractures, it's bad news, because blood does not like to see the semi-solid fat escaping into the bloodstream. It tries to seal the fracture by placing a clot on it. And guess what happens? If you have 10% or 20% residual lumen here, that's immediately all clotted. So you go from an instantaneous 70 or 80% blockage to 100% blockage within a matter of few minutes when there's plaque rupture that leads acutely to a heart attack. So that's how statins actually can prevent one from having a heart attack, just because they can strengthen that lid and prevent it from fracturing or rupturing. This is an emergency. I mean, when somebody undergoes an ST elevation myocardial infarction, they look very sick. These patients usually, textbooks describe them as profusely sweaty. Even in an air-conditioned environment, they sweat. The patient sweats. Something is wrong. And sometimes they have a look on their face, a sense of impending doom. This is actually classically described in books. And it's just a very, very bad, it's a very dismal situation to be in. Immediately, the artery needs to be opened, and you need to be rushed to the nearest emergency room so that could be taken care of. So this is an acute heart attack caused by plaque rupture or plaque erosion. Now, other clinical conditions we encounter in clinical practices, we have a patient, we've done a stress test. The stress test looks abnormal. We did a cath, but there is not significant blockage. There is no need for a stent. But this person has microvascular disease. Look at this beautiful. See, these arteries just don't end on the surface of the heart. they divide into smaller and smaller branches. They dive into the walls of the heart muscle. It's almost like the fine roots of a tree or a plant. And these are so fine that you can only look at these arterioles under the microscope, and thereby we call them microvasculature. And it's also called endothelial dysfunction, microvascular dysfunction, because these microscopic arterioles are the ones that are eventually responsible for providing blood and oxygen to the walls of the heart muscle. So if the parent arteries are patent and the patient has classic symptoms, exertional angina, shortness of breath, then certainly it's worth a trial of certain medications we use to see if it helps the microvascular dysfunction. So this is one condition. Prince-metal angina or vasospastic angina is another condition where you can actually see the ECG change. The person's ECG changes, they have dynamic ST elevations during the time of chest pain. So if someone were to get an EKG at the time of chest pain, they'll have the ST elevation. Then as soon as the pain goes away, when we treat them with sublingual nitroglycerin or some other antispastic agent, when the pain goes away, the ECG becomes normal. So this is vasospastic or Prince-metal angina, can be well controlled with just medication, responds very nicely. These don't really have a true blockage, or they may have a blockage, but the stent is patent. But certain people will have what's called vasospasm, where the muscle of the arterial wall likes to squeeze down on itself. So it mimics a blockage, thereby cuts off blood flow and oxygen to the wall of the heart muscle, and thereby triggers an anginal episode. There is another condition which has become quite popular, and I see that quite a bit in women, rarely in men. It's also seen in men, though. I shouldn't say mostly women, though. It's called a stress cardiomyopathy, where, intense emotional stress can cause a certain release of hormones, that sympathomimetics, meaning increasing blood pressure, increasing heart rate. And it can actually cause something like a true heart attack and cause, even troponin elevation. When you check blood work, it looks like a heart attack. You do an angiogram on the patient, there is no significant blockage or no blockage at all, period. But they do have a ventricle that doesn't squeeze well and is able and actually looks like the person's had an acute heart attack, but there's no blockage. This is called a stress cardiomyopathy and typically is seen with severe amounts of stress. Mental stress certainly causes it. And that's called Takotsubo, or an octopus trap, where the apex does not contract, but the base of the heart squeezes really well. And again, that they think is because of microvascular constriction from the sympathomimetic release. So here is, I don't want to get too technical, but in women though, look at this, polycystic ovarian disease, that's another syndrome, polycystic ovarian syndrome, hypoestrogenemia and menopause causes hormonal alterations. This then adds on to hyperlipidemia, hypertension, smoking, metabolic dysfunction, inflammation. It creates an ideal setup to actually develop atherosclerosis and microvascular dysfunction in women. And sometimes early menopause can actually trigger this sooner rather than later. And then it leads to symptoms. And then if you do an angiogram, you can see that diffuse atherosclerosis, you can see the diffuse narrowing. If you do a stress test, you can actually see subendocardial ischemia in these patients. So here is, again, normal blood flow, normal arterial wall. This is what happens with women. You see how there's diffuse disease in the wall, but there's also microvascular dysfunction. But women also get stents. I mean, they can have true blockages like men do. So they come in all flavors. I mean, it could be an acute, a significant blockage needing a stent. It could be diffuse atherosclerotic disease. It could be microvascular dysfunction. It could be any. It's just a spectrum. So what does the LDL cholesterol do to us? Everything, right? Outside the heart, it does retinopathy. Look at that. It affects your arteries in the eye. It can cause peripheral neuropathy. It can cause peripheral arterial disease. And of course, it can cause a heart attack or myocardial infarction. So outside the heart, it affects the peripheral arteries. It can affect the arteries in the eyes. The retinopathy also can be caused by it. And if one has diabetes, it is more so in combination. Again, this condition is called ischemia with non-obstructive coronary disease. We call it INOCA. It's a physician's term. I think in lay terms, we just say it's you can say that it's heart disease, or you just say chest pain, angina without a blocked artery is really what it's trying to say. It's called INOCA, which is the medical term for it. And then obstructive coronary disease is when there's plaque rupture and acute heart attack. This is the picture I was talking about. You see, this is the arteries we see by angiography. So whenever we do an angiography, this is what we see. But we don't really see this. This is the microvasculature, the coronary microvasculature. You see how tiny, tiny these arterioles are? But they are the ones that are really feeding blood and oxygen to the walls of the heart muscle. And so if no stent is needed, we can go on to put them on optimal medical therapy in order to improve the blood flow and oxygen through the circulation in the walls, and thereby, help them with their angina or chest pain, shortness of breath, whatever symptoms they have. And this is just another picture. Not only does it affect the eyes, when you have atherosclerosis, it affects the heart, it affects the eyes like we talked about. It can affect the brain, vascular dementia, lacunar stroke. It can affect the kidneys. It can cause chronic kidney disease and ischemic nephropathy. So here are some of the stress tests we use. This is the nuclear stress test, and these are rest images. This is slices through the left ventricle. This is at rest, and this is with stress. Notice the difference. During stress, there's complete loss of blood flow to the bottom of the heart. Look how nice it looks at rest. With stress, this is what happens. So this is how we look at these scans. So if somebody looks like this, it's raising suspicion that the artery that supplies this area has a tight blockage greater than 70%. So these are the patients we'd like to refer for an angiogram and stenting. Coronary CT angiography, we have the 4th generation CT scanner at the heart hospital, and we are able to look at these arteries just with CT imaging, and it gives us a good idea of whether this person has a tight blockage or not. So this has also become quite a popular modality. And here is the true angiogram. Oh, this is CT. Here's a person who's got, sort of diffuse, slight narrowing here, diffuse disease. Here's a tight narrowing. This person needs a stent. And here is somebody who's got diffuse plaque. As you can see, this black thing here is the cholesterol plaque on CT. That's how we define the disease process in CT. And then when we send the patient to get a cardiac cath, tight blockage, we've put the stent in, and this is what they look like immediately. So what can South Asian women do? It looks like the race is sort of very, very high risk, unfortunately. So people have to, even earlier on in life, even when you're in your 30s, even 20s, 30s, good habits, you need to start early. So eat healthy most of the time, regular physical activity, try to avoid abdominal obesity, and really have to exercise 30 minutes daily, moderate intensity, walking. Moderate intensity is described as you walk, and if you try to speak to somebody, you should be mildly short of breath. Or if you sing a song to yourself or something like that, it can make you a little short of breath when you're doing your brisk walk for 30 minutes. So that's moderate intensity. And at least 5 days per week, is recommended. And decreasing all the processed carbohydrates in food, such as white rice, and avoiding trans fats is very important. And you want to avoid abdominal obesity. Lastly, I wanted to touch on, COVID and the heart, right? With COVID, there's a lot of patients that come to see us. They have chest pains, shortness of breath, they have palpitations that they never had before they tested positive for COVID. They had symptoms like a mild or slightly more intense upper respiratory or lower respiratory symptoms, but eventually they're left with, pain in the chest. Doc, it hurts when I take a deep breath in, I'm short of breath even when I do, mild to moderate activity. Previously, I wasn't. So how does COVID really affect the heart? I think it's interesting for everyone to know, since, we are living through this pandemic. So it can cause anywhere from plaque instability and rupture to an acute heart attack. Remember, I showed you that picture where you can rupture or fracture the plaque. So actually the infection with COVID can do that. It can also cause myocarditis, where this inflammation of the walls of the heart muscle can cause fulminant myocarditis, acute heart failure, and sometimes patients die from it. It's just a very It's a multi-system disorder when the COVID strikes, the heart, the lungs, and the brains. It's sort of a multi-system disease, and it really can affect any organ. And I think it's important to understand that COVID by itself can cause a heart attack. COVID by itself can cause blood clots in the lungs or pulmonary embolus, can cause deep venous thrombosis, can cause acute heart failure from myocarditis. It can cause pericarditis, where it is inflammation of the sac around the heart because of the virus. It can cause arrhythmias. Anytime the heart muscle becomes inflamed, it becomes highly irritable. And so if that happens, it just sets off some malignant arrhythmias, very rapid. Patient can suffer from cardiac arrest just from the arrhythmia itself. COVID can cause inflammation in the lungs. Since the lungs and the heart are almost one unit in the chest, if one is severely affected, the other one suffers quite a bit. So if the heart is affected, the lungs suffer. If the lungs affected, the heart suffers. And of course, in the arterial system, it can cause blood clots because it creates this hypercoagulable state or a thrombotic state. And really, I think that those were the main things I wanted to touch upon. And if there's any questions, I'm happy to take any questions.
Thank you, Dr. Gopal, for an insightful and eye-opening presentation. Now we will now dive into a quick Q&A. Can you tell us about heart calcium scores and how it predicts or correlates to heart disease?
Absolutely. So that's a great question. So the CT calcium score is a very, very popular screening test that we use. And I think it's very helpful in the Indian population because we develop heart plaque much earlier than other races. So even if somebody is in their 30s and they have a family history of heart disease, early heart disease, I think it's very important you go get the calcium score done. It's a very simple test. We don't inject any dye in you. It is done without contrast. And it takes only maybe at best 30 seconds to get the test done. You lay on the table of a CT scanner, it takes a photo of the surface of your heart, that's it. And then you get off the table. We feed that data into the software, into a workstation. We have a software that's able to calculate if there is any flecks of calcium on the surface of the coronary arteries. Then we create a score. 0 is ideal. Everybody wants to have a score of 0. And if not, at least we'll know what it is. And the strength of the test is, because we have a very huge database of patients that are already scanned, we can compare you to other people your age. And it is age and gender matched, for percentile. And we can determine how much, at what level of risk you are. The reason somebody has even calcium on the surface of the artery is because they already have cholesterol developing in the wall of the artery. If the artery were clean, you would not see the calcification. So that's how it's helpful.
Okay, so what are the effects of menopause on a woman's heart health?
It's multifactorial, as I said. It is hypoestrogenism. Estrogen really, in the premenopausal years, at least in the Western society, incidence of heart attacks is low, okay? But in India, or Asian Indian women, the premenopausal age is not exempt. We have women that have been bypassed even in their early 40s or late 30s. And that's an age that you're not supposed to have heart disease. Menopause, the way it affects us is it withdraws the hormones, so essentially there's a fall in your estrogen, progesterone levels. This makes the arterial tone very sort of non-compliant. It's not as compliant and smooth. It becomes sort of stiffer. It increases vascular resistance. It increases one's blood pressure. And thereby it can set up a trigger of events. It can cause dyslipidemia. It can cause your metabolic syndrome, maybe impaired glucose tolerance. Everything sets in around menopause because that's also the age where people start getting a little heavy around the belly. So all of that kind of, work together, and it's a perfect storm then to start developing plaque and heart disease down the line.
Okay, moving on. Now, what can we do about high Lp(a)?
It certainly, has to be measured, and we have labs that do that. So when you talk to your primary care doctor, have them, draw it for you, or see a cardiologist that does it. And we have medications that we use, fenofibrates, estrogen actually lowers it. So, but you cannot treat with estrogen. So niacin, fenofibrate, statins certainly will be used to treat or lower your Lp(a) levels.
Are there any supplements that are recommended for heart health?
As I said, we didn't do herbal medicine, so it's very, very hard for me to answer that question. But I know a lot of patients like to take something over the counter, like the natural, lower your cholesterol, the plant stanols, plant sterols. Some people take, red yeast rice, but red yeast rice is a fungal-based statin. It's a weak statin. That's why, it works. So those are some of the supplements. I think if you eat healthy most of the time, and if you have a healthy lifestyle, and if you're aware about the risk factors of heart disease and you're taking all the necessary precautions, I think, with plus add on a calcium score to see if you have early plaque buildup, make sure your annual labs are within normal limits. I think that's the best we can do.
Okay, so staying on the topic of supplements, for cholesterol, do you recommend any herbal supplements? Because I hear garlic pills being recommended.
We went to medical school to learn about our medicines. So I am not an expert on herbal medicine, and I choose not to comment on it because I don't know. So
Okay.
I would rather not. And we don't know how they interact with the medicines prescribed by the doctors here. So we don't know what it does to your blood pressure medicine or to your, statin. There is no, documented interactions. There is no data. So really, if you're taking it, you're just taking it, but there is no data to support it.
Okay. So for someone over the age of 60, how often do you recommend that they see their cardiologist for regular assessments if they are at risk for heart disease or maybe they have cardiac disease in the past?
Yeah. If there is a family history of heart disease, first of all, if there's a family history of early heart disease, I would encourage everybody to go even at age 40. Get a relationship with a cardiologist every 3-4 years, just go see them. It doesn't have to be every year that you need a stress test, but make sure that your risk factors are under control. I would say every few years you need a stress test. If you have early heart disease, if you don't have early heart disease in the family, I think a good place to start would be age 50 is a good age to start because, with modernization, with, everything, there's more stress in people's lives. So, past the age of 60 is not anything set in stone. I would say if anybody wants to go on earlier on, they should go on and get checked.
Okay, so you do recommend that
I do recommend every few years. Yes, absolutely.
and starting from age 40, did you say?
If there's early heart disease in the family, you should be all over it right from the start,
Okay, a good point for all of us to remember. So this question is from a person who is about 65 years of age, and she has a lot of indigestion and she gets chest tightness. And she says that she gets relief when she takes antacids, and she wants to know if she should see her doctor and be concerned about, or rather test for more serious conditions.
Yes, absolutely, right? Because women can present with indigestion, and even though it responds to Tums, you're 65, so age alone is a risk factor for heart disease, regardless of whether you have other factors or not. So it's very important you see your doctor, get an EKG done, get a stress test done, see a cardiologist, and get everything done, and make sure, if there's a blockage, they treat. If there's no blockage, at least then it's indigestion, go see a gastroenterologist.
Okay.
Because the heart can never wait. The stomach can wait.
Right.
Difference, right? Because the heart's always an emergency.
Mm-hmm. Okay, with that, we come to an end to our session today. Please stay tuned for announcements. Over to you, Poojaji.
Thank you.
Thank you, Dr. Deepika Gopal. We had an awesome and amazing, very informative session. Really thank you for your time and coming over and answering so many nice questions. The way you went over your presentation was so easy and informative to understand. Thank you for explaining it in a layman's level. We could understand it really well. I'm sure all our viewers would love to see now, and it's on YouTube, so they will continue seeing it. So at the Radha Krishna temple, we have a few announcements.
Thank you, sir.
think my voice. Okay, we're always enthusiastic to celebrate. We have Valentine's Day coming up, and for Valentine's Day we celebrate the Gopi Prem Divas. It is a beautiful day. Sri Maharaji Kripalaji Maharaj named it Gopi Prem Divas to do devotion to Radha Krishna, and we will be celebrating from 9:30. So to take advantage of this program and register online, you will find more information on radhakrishnattemple.net/PYC. You could go register. You see a bunch of sessions, yoga sessions, meditation sessions, pranayam sessions. Office yoga is very popular. So check out those sessions. I don't know if this is kind of too small for you to see it. I can kind of. When you actually come over here, you will also find a place where you can register. We have the annual membership, that's $75. You can do your registration here. After you finish your, and definitely use the code to avail that offer. And once you finish your registration, you will receive an email to download the mobile app and book your classes for throughout the year. With that, we will be starting the JKYog Daily Wisdom from Bhagavad Gita at 9 o'clock today, and do check that out. We will conclude our session with that. Thank you and have a good night.